a lot of excitement about the next topic, which was the new immune therapies in particular. And so obviously the highest visibility for the CAR T programs, and also the new BiTEs, the bispecific T-cell engagers, as well as a new IMID, basically a CELMOD coming after the thalidomide, Revlimid, and pomalidomide. So just a little bit of data that has been presented recently. We have updates on the BB2121, which is the Celgene Bluebird CAR T product. Basically, just a little bit more follow-up indicating the value, the length of the remission, and the achievement of MRD. The number that people focus on is that the median duration of PFS is 11.8 months, and so people are balancing that length of response with what it takes to achieve this sort of treatment and the cost of this treatment. And then the big thing that's happening right now, and this is just another example that was presented, another type of CAR T cell. So we're seeing next generation CAR T cell therapies, many of them with different types of advantages, improved efficacy and safety. We are seeing fully humanized CAR Ts. We're seeing different target combinations. And so certainly it's not the end of which will be the best CAR T protocol, that's for sure. And then, of course, a lot of excitement about, well, perhaps the bispecific engagers would really be a good alternative to the CAR T. And so tremendous interest in this particular product, the Amgen 420. And just a little bit of follow-up. The first presentation on this was a dose finding, and definitely concern at the higher dose level of the 800 micrograms, where some unexpected, rather strange neuropathy occurred, which fortunately does seem to be reversible, but it led to a little bit of an expansion at the 400 microgram dose, but really limited data so far, 10 patients actually, with a 70% response rate, although they did indicate a 40% MRD level. So it's going to be interesting. I'll be interested in your thoughts about how this will move forward. And then, interesting just to see with this early data with the new CELMOD, CC220. This was presented by Sagar Lonial in patients who have been previously exposed to Revlimid, pomalidomide, overall response rate of 31%. And so I think credible evidence of benefit here. We need to see how that might move forward. And then, of course, we are seeing a lot of information about selinexor, the STORM, the original selinexor dexamethasone, and then in combination with DARA, quite interesting. And there is expectation that selinexor will, in fact, hopefully receive FDA approval. We'll see how the FDA views the final follow-up on that. And so what's your perspective on those new therapies? We really do have so many options in terms of the CAR Ts, the BiTEs, and then we have these promising other agents. And so, Joe, what do you think? Let's take the CAR T cells and the BiTEs. What's your perspective on what's happening there?
Yeah, I mean, from the scientific
yes.
geek in me goes crazy over this stuff. I mean, this is fantastic to think that we can, you know, take T cells out of a patient and train them to go back and fight the patient's tumor, or have a drug that puts one arm on the tumor and one arm on the T cell and gets them together. I mean,
yes.
The science is overwhelming.
Yeah, tremendous.
But I think, you know, that's why I think the word CAR is appropriate for it, because it's kind of like early model cars, right?
Yeah,
we all
CAR
knew
T.
that they needed some help, right? So I feel like when we go to these presentations now, it's like we've got a car that's got more horsepower, or has a better sunroof, or has a better stereo system. Like, we're constantly making the cars better.
Yes.
But, you know, joking aside, like I think the challenge with CAR T cell therapy is going to be, one, that it's in a sense a boutique therapy. You know, if we have difficulty getting a simple autologous stem cell transplant to patients, and we hear all the time that even in the U.S., 40% of people who should get a transplant don't. It's going to be even harder for patients to access an expensive study that requires, you know, collection and machinery and you know, the creation of or all the work that we have to do with the T cells to multiply them and give them the receptor and give them back. So that's why I think I might be a little bit more excited around the bispecific concept, but it's also early on. I mean, right now, the AMG 420, this is a 28-day infusion.
Continuous infusion,
so patients are getting
drugs.
Although
they do have the 701 coming along behind.
Correct. They have ones and that's what I mean, that further ones coming along. There was a really cute quote, a tweet from one of the prominent patient advocates at ASCO saying, well, if you're going to make me wear a backpack for 28 days, it better be a cute backpack. You know, but I mean, it is still, there are still challenges, and I'm concerned about the neuropathy that you mentioned.
Yes.
Because when we saw the first presentation, it was one patient. When they updated it, it now happened in 2 patients. And any, you know, problem that we can't explain or adverse event we can't explain is a bit tricky. I don't think it'll be the end of bispecifics. If anything, I think it's just an early step forward. So I'm very excited about the concept of being able to, if you will, take it off the shelf as opposed to going to CAR T. I think CAR T will play a role, there's no doubt, and we'll probably bring it earlier in the disease. I'm just not sure CAR T cell therapy is for the masses, as it were. I think it's going to be really in a narrow group of patients.
So what's your take, Philippe?
Well, I fully agree. In fact, we have now 3 different classes of agents targeting BCMA, because the most important target is BCMA that is always expressed on the tumor cells. And then we have the CAR Ts, that's one shot, but we have this manufacturing process of more than 4 weeks, 5 weeks, and we know that patients may progress during this period of time. And this is a big issue, because not all patients are able to receive the CAR Ts. And then we have these drugs, either the BiTEs, and they need to be improved. As you mentioned, the continuous IV infusion is not feasible, in fact, in routine for the patients. And we also have these antibody drug conjugates, and one is in development from GSK.
Yes,
very interesting. That's a weekly infusion only. The drug is immediately available. It's off the shelf. So you can use it, in fact, immediately when you have a very advanced patient.
Yes.
But we do have some drawbacks and some ocular toxicity.
But that does seem to be manageable in that case.
It is manageable, but, well, nevertheless, that's not, well, we still have to learn. So we have these drugs in development. Who will win? Single-shot CAR Ts or other drugs? That's, well, that's really challenging, but that's fascinating for sure.
Yeah. Okay. So you just touched on it. So these are being offered, obviously, in the relapse setting right now. What's your prediction in terms of some of these moving forward into earlier disease or even frontline? One comment I'll just make to introduce this is that the immunologists in our group are making it clear to us that the expression of BCMA is not 100% and you know, is varying from cell to cell, and so we need to be cautious about hoping that it will be a truly decisive therapy. Even if we move it up early, maybe it won't be able to eliminate every cell, you know. I don't know what you think about that.
I agree that maybe the best way of using CAR Ts would be earlier in the course of the disease. One shot in patients with a very low tumor burden, potentially almost MRD negative, or in CR but MRD positive, and mostly in high-risk patients. We have to try to treat patients with 17P, for example, or early relapse after stem cell transplantation. Those kind of patients, very difficult to treat, in fact. So I'm really thinking that we should try to use them earlier.
Yeah, I agree. I think partly the other challenge is that when we compare CAR T cell therapy in myeloma to, let's say, CAR T cell therapy in lymphoma and leukemia that have been so successful, almost curative in some of those conditions. Now, granted, some of those diseases are different. Obviously, we're in a sense comparing apples and oranges, but I think we've seen that although the CAR T-cell therapy may have a very deep response and lasts that 1 year, after that time we do see quite a trail off. And so maybe, younger T-cells that are earlier on in the disease course.
You're talking about harvested sooner in the disease course.
Exactly, harvest them sooner. Maybe they can be charged for longer, right? Maybe this is, I don't know, like a hybrid car or something.
Or even selecting the exact type of T-cell to engineer.
Correct, because I think by the time we're giving these CAR T-cell therapies to patients very late in the disease course, we're trying to engage their immune system, but their immune system is beaten down and weakened and may not have. But I absolutely agree with Philippe. I think he said it so nicely that I think we have to select in that highest risk patient, where right now we really struggle with what to do. And in that situation, it may be worth that extra time and effort and challenge of getting CAR T-cell therapy to them if that's going to be able to control their disease better.
Yeah, absolutely. Okay. So what I did here is I picked a number of the most prominent abstracts, and these are a few others, just examples of things that were presented. One you already touched on, Philippe, which is the GSK, the
916.
The 916.
The last abstract that you mentioned.
Yes. So,
well, the data were published twice, in fact, and recently updated in Blood Cancer Journal. And the median PFS in very advanced patients is almost is very close to that is observed with CAR T. That's 1 year.
It was right around
PFS,
1 year, right? Which is
now the company has completed a very large phase 2 study. We are going to have very soon phase 3 data as well, because this drug will be compared to Pomdex, will be compared to DARA-based combinations as well. So I'm quite confident on this GSK 916 compound.
So what do you think?
I agree too. I mean, going back to the concept of it again, almost like a CAR T-cell light, like not having to go the full way, a little bit different than the bispecific
but off the shelf.
Yeah, off the shelf. It targets BCMA and then sort of drops a poison inside the cell after it's grabbed onto the BCMA. For those who may not be familiar how it works, so the concept makes a lot of sense. I agree. The results are really dramatic. It seems to be, in general, an easy drug to administer. There are these corneal challenges that we're trying to work through. What happens in the eye and what's the mechanism of it? We know that all monoclonal antibodies can actually get into the eye, but we're trying to understand this a little bit better. It gives people a bit of mostly just blurriness of vision that with time resolves. So that's good. The question is really if there's a way we can prevent it better. But I think that concept is critical. Being able to give an off-the-shelf drug that has that kind of efficacy that's not a 28-day infusion. I mean, I think this is going to be very important for myeloma patients, for sure.
One other I'll perhaps just highlight, the prognosis for patients with 1Q plus, and so obviously we focused on this a little bit more recently, and we've added it to our high-risk categories. However, there's a lot of things go on with chromosome number 1, and I'm not sure what is the best way for us to assess all of those changes, the 1Q plus or the number of amplifications, all these different things. And so, so what do you think about the role of assessing the 1Q abnormalities or chromosome 1 abnormalities? You actually presented this in your high-risk discussion.
Yes, no, and I think there was actually quite a bit of consensus amongst our working group that this is an important thing. I think we've always said, and we've said it so often during these presentations, Brian, myeloma is not one disease. It's such a spectrum. We have patients that have very slow-growing disease, almost indolent-like disease, as we call it, and those who have very high-risk, rapidly growing disease and everything in between. And sometimes there's been this discordance where we look at some of the numbers, you look at how a patient's doing, well, is that a high-risk patient or not? And I think defining that high-risk category is really important. And our traditional markers of the key chromosomal changes that we've defined with P53 deletion and key translocations are there. But I think this 1Q is real. And I think the French led the way, actually, in helping us understand this better. And so I'm sure Philippe has more comments on it. But now, as with every updated database and registry, we're starting to see, actually, this is a real phenomenon.
Yes, so this was actually going back to the original total therapy experience to show that even in that setting, the 1Q was important.
Yeah. Well, we have recently defined a new score.
Yes.
the paper was published a few days ago in the GCO with a combination of several genomic abnormalities, including 1Q abnormalities. So definitely it is a very important factor to be assessed at the time of diagnosis, and also sequentially at the time of the relapse as well. But in fact, very few of us, we are selecting a specific treatment option based on these abnormalities.
Yeah, so what do we do for 1Q plus, right?
That's it, in fact. So I think that, and we discussed this during the International Myeloma Working Group meeting in the last 2 days, we should have specific trials focusing on high-risk patients to try to identify the best options for them.
Right, right. But it is tricky because if we look at 1Q plus, which by the way we can, there is an interesting study just started at UCSF. The 1Q plus patients do overexpress CD46, and so they have a monoclonal antibody targeting that. And so I don't know if this is the way for the future. For each subgroup, we will have a specific strategy. We have obviously for 1114. 1Q plus, and maybe 17P. Maybe yes.
Yeah, it was striking to see that. I think when we did the survey of the working group, 73% of our International Myeloma Working Group agreed that they approach the treatment of high-risk patients differently than standard risk, and it seemed that that approach was including a proteasome inhibitor, being a little bit more aggressive in the combination that you're using, and treating with the really making sure that their disease gets a deep response, and then continues until relapse.
Maintenance with the PI,
and
not maybe an IMID. In Europe, tandem stem cell transplantation in high-risk patients. So yes, that's true. We are treating them differently.
Right. So what do you think about some newer data where these factors are important certainly early on and maybe later in the disease? However, later in the disease, it may be that completely new and additional mutations like KRAS and NRAS and other mutations could be driving the relapsing and progressing disease. How do you think about that?
Well, we are assessing systematically at the time of each relapse, but that's only for, to collect the data and to try to see if a specific treatment was able to overcome this, the occurrence of a new abnormality. But, well, we are not treating according to a new finding.
But not yet. I mean, look at the whole cancer world is going this way, right? We have these so-called basket studies and different trials where we're doing studying the genomics as deeply as we can in a tumor. And, we've seen this in myeloma. We had a case in our clinic a few years back where we did this deep analysis and found that this patient had an unusual BRAF mutation, so something that we might usually see in a solid tumor, and we were able to get them a BRAF drug, right? So we had to call our solid tumor friends and understand it, because even though myeloma is a distinct disease, it seems that later and later in disease course, cancers sadly become a little bit more alike. And so if we can take that genetic information, really personalize it. Now this is challenging because I don't want all the patients listening in to say, oh, I need that test because I want to know what's most right. Because it's still a very small percentage of people. But I think as we gain this information, we find that somewhere around 8% of patients have a BRAF mutation, or as you mentioned, the KRAS and NRAS. We don't have specific therapies for them yet. A lot of work is being done to try and develop.
But for the audience, maybe we have to explain that not all the cells are harboring the mutation.
Correct.
And well, one point is that BRAF, that's 5 to 8% of the patients that are mutated, so that's very few, in fact. But inside the group of patients with a mutation, some of them have this mutation only on 20% of the cells.
Correct.
So it means that 80% of the cells will not respond to a specific treatment targeting BRAF. So we have really to be careful when claiming that we can use targeted treatment. That's not that simple.
Yeah, so I actually fully agree with that. And there's some recent single cell analyses that really reinforce that. If you look at that subpopulation with like 1Q plus or 17P, if you look at the subclones, they have multiple additional mutations that would be challenging to overcome, in fact. Okay, so are there any final things that you would like to emphasize both of you are involved with clinical trials. What do you see as the key next trial or trial that was going to inform us most, that you're, of all the different trials that are coming out, that will be the most informative as we're trying to think of our next best therapies?
Well, we've got almost like an alphabet soup of trials.
I'm saying this because we heard about so many trials at the end of our summit, but is there one or two trials that stand out where we really need the answer?
Well, in the frontline setting, for me right now, I think working on Philippe's great work with the Cassiopeia study will be this Griffin study, where we do daratumumab, bortezomib, lenalidomide, dexamethasone. That quadruplet, we need to see that study and really prove that adding DARA, it makes a difference to those patients. I think that could have the greatest impact in the short term, at least in frontline patients.
I agree.
Yes.
Definitely, that's we are running the enrolling patients in Europe, all over Europe.
Right.
In the EMN Perseus study with VRD plus or minus daratumumab, stem cell transplantation, and a fixed duration of maintenance, and we are comparing LEN versus LEN-DARA maintenance, 2 years. And I think that we can have a subgroup of patients that will never relapse. We have a serial assessment of MRD, and for those patients reaching MRD negativity very early after induction, for example, and before stem cell transplantation with a quadruplet combination, maybe those patients will receive the entire treatment and will remain MRD negative during a very, very long period of time, maybe potentially cured.
Yes, yes. So, well, that's good to end on a note like this, where we can envisage a combination that will give you MRD negative and maybe be sustained in that way. That's very encouraging. And so I would say a takeaway message for me is that all of these trial results give us so many options and so many things that could really have a powerful impact for our patients. And so I think that in closing, I'd definitely like to thank both of you guys for coming. I know just getting here was quite a challenge for Philippe, and sticking around to do these extra things we really, really appreciate. So thank our audience today, and especially thank our sponsors. And we hope you enjoy this, and you'll be ready for the next time that we report, which I think will be from ASH. So thank you for your attention.